We are live now, doctor.
Hello, everyone. On behalf of YOSI and YOSI Oculoplasty Focus Group, a very warm welcome to all of you for our third episode of Oculoplasty Case Presentation Series, ExPresYO, which is expert guided presentation by young ophthalmologists. So this initiative actually arose from a casual conversation between Dr. Puneet Jain, who's the team lead of the focus group, and I on how every resident and fellow should be guided to present cases at national and international platforms, regardless of their institute or medical college. This is a unique initiative where every presenter is guided by a mentor, which they can choose or we assign if not available. So making it competitive is only a secondary objective. And we have also collaborated with Yo Slides team who share the same vision from YOSI. So this is our third episode, and the first two episodes were on the lacrimal system and the eyelid session. So now I would request Dr. Prasanna Venkatesh Ramesh, who's the Joint Secretary of the Young Ophthalmology Society of India, to introduce our international faculty and also speak a few words.
Good evening, everybody. Aishi, thank you for the opportunity and this wonderful initiative. It's nice to know that two YOs, when you had a candid conversation, which has led to such a wonderful series of ExPresYO. And kudos to you for the third episode and even the amount of work you guys did for the Yo slides. It speaks for itself in our archive. And at this moment, I would like to welcome Professor Dr. Rohit sir. Sir, thank you for taking your time and being here with us today among the young ophthalmologists of YOSI and beyond. Sir is a senior visiting consultant, Tilganga Institute of Ophthalmology, Nepal, and he's also a global leader, founding president of NESOS, the force behind Nepal's first national ophthalmic oculoplasty conference in 2010. Over 2 decades of experience in managing cataract, eyelid tumor, MD in ophthalmology from the BPK LCOS Tribhuvan University in 2001, and many awards such as the APAO Distinguished Service Award, the Travel Grant Award, the APAO Achievement Award, and the SAO Excellent Service Award. Sir needs no introduction, but we at YOSI are very happy to have you here, sir, today. Thank you for your time, for being here. Along with you, I would like to welcome a good friend and a senior, Dr. Akshay sir, Dr. Ruchi, Professor Ruchi, Dr. Tarjani Dave ma'am, moderators, Sumir Doctor, the case presenters, and the whole team, the mentor panel, as well as Dr. Puneet, Dr. Nupur, Ritwija, Nupur ma'am, and Rolika and team. You guys are doing a phenomenal job and you're taking YOSI much more international heights. And I would not stand in between this and the program. From the GC side as well as from the executive team, we are very happy to have you, sir. Welcome, Dr. Rohit, sir. Welcome.
Thank you, sir.
Thank you very much, Prasanna, for a nice introduction.
Thank you. Thank you, sir. Thank you.
Thank you for a nice introduction.
Thank you, sir. Thank you for being here.
And for the invitation to join with you. This very unique type of webinar. Thank you.
It's always a pleasure, sir. Thank you, sir. Thank you for being there for YOSI. Thank you.
Thank you, sir, and welcome on board. Now I would like to request my co-moderator, Dr. Sumer, who's currently a fellow in ophthalmic plastic surgery and ocular oncology services at LV Prasad Eye Institute, Hyderabad, to kickstart this session by introducing our judges and our first speaker. Over to you, Sumer.
Thank you so much, Ayushi. I want to thank YOSI and Ayushi for this amazing initiative, and thank you, Prasanna sir, for joining. With Professor Dr. Rohit, we have three very wonderful expert panelists with us who will act as judges as well as interrogate the next four presenters. And hopefully we'll have some interesting discussion along four very interesting cases. So the first panelist we have is Dr. Akshay Nair. He is currently a consultant at multiple eye hospitals, including the Agarwal chain of hospitals in Mumbai. He completed his fellowship from LV Prasad Eye Institute as well as a fellowship in orbital surgery and oculoplastic surgery at Mount Sinai, USA. He has multiple awards and over 140 publications to his name. But what's very interesting to note is that he's amongst the top two percent scientists as per the Stanford 2024 publication. So despite being so successful in private practice, he has stuck to his love for science, so which is amazing, and hopefully we can get great insights from him. With Dr. Akshay, we also have, Ayushi, if you can have the next slide, we have Professor Dr. Ruchi Goyal. She's currently a senior consultant at the I7 group of hospitals. And she has, as we know, been the ex-director of the Maulana Azad Medical College in New Delhi. And she has multiple publications and awards to her name. She will join us a bit late. And we also have Dr. Tarjini Vivek Dave, who is the current Associate Director of the CAR campus, the Hyderabad campus of the LV Prasad Network. She's as of now, the Acting General Secretary and Joint Secretary of the Oculoplasty Association of India. After her fellowship at LV Prasad, she has now continued to be a senior consultant there, and she also heads the ocular history department. I work with Dr. Tarjini, and I can tell you she's extremely innovative and she's an amazing teacher. And I'm sure that every CT and MRI that is put up today is going to be dissected in detail, and we are all going to be quizzed on it. So we are all looking forward to a great session.
Thank you so much. I would now
We'll,
request. Yeah.
We'll begin with the session. Ayushi, if you'll introduce the first presenter.
Yeah, so the first presenter is Dr. Palak, who will be presenting an interesting case with the mentorship of Dr. Narendra Patidar, who is the head of the oculoplasty services at Sadguru Netra Chikitsalaya, Chitrakoot. Yes, Palak, we can see your screen.
Ma'am, is my screen visible and my voice is clear?
Yes, completely. You can start.
Good evening, everyone. First of all, I would like to extend my sincere gratitude to Yossi for granting me the opportunity to present on this esteemed platform. Today, I will be presenting a case titled More Than Meets the Scan, Cystic Twist and Orbital Xanthogranuloma. Juvenile xanthogranuloma is a rare benign proliferation of non-Langerhans cell histiocytes. It typically presents in infancy or early childhood. While cutaneous involvement is common, about 10% of patients with skin lesion may also develop ocular involvement. Iris is most commonly affected structure, but it can also involve the eyelid, conjunctiva, orbit, choroid, retina, and optic disc. As described by her mother, a 14-year-old girl came to us on October 2023 with chief complaint of periorbital pain and fullness in lower lid since 1 year. She had a past history of left eye myocysticercosis with cystic granuloma and inferior rectus muscle 10 months back, as we can appreciate on the B scan attached, for which she took tablet mebendazole 100 mg OD and tablet prednisolone in tapering doses. Family history and systemic history was not significant. On clinical examination, right eye was within normal limit. Left eye had vision of 6 by 6 with 2 mm of superior displacement of globe, causing pseudotosis of 2 mm, MRD plus 1. Finger inclination was absent in inferior quadrant with mild tenderness. There was resistance on retropulsion. On palpation, firm, smooth surface, compressible, non-reducible mass was present in inferior orbit. Posterior extent of mass could not be assessed. Extraocular movements were full and free in all of the gazes, and no lymphadenopathy was present. On contrast enhanced MRI, as we can appreciate, well-defined lobulated T1, T2 isointense lesion was seen involving the distal aspect of left inferior rectus muscle, showing peripheral post-contrast enhancement in sagittal section with subtle diffusion restriction. So, on the basis of clinical examination and imaging, we were suspecting a well-defined cystic mass in the left orbit. Our differential diagnosis were cysticercal granuloma in inferior orbit and epidermoid cyst. Patient underwent inferior orbitotomy via transconjunctival approach with excision biopsy under general anesthesia on 25th of October 2023. Intraoperatively, a solid mass was found which was adhered superficially to the inferior rectus tendon, and no bony adhesion was seen. Mass was well isolated and sent for histopathological examination. On histopathological examination, Grossly, a grayish-white solid mass of 2 into 1.5 into 0.7 centimeter was found. On histopathology, focal collection of lymphoid cells with histiocytes and foamy macrophages, along with totten giant cell and focal area of necrosis was seen, suggestive of xanthogranulomatous inflammation. So, on the basis of previous examination, final diagnosis of juvenile orbital xanthogranuloma was made. As in literature, involvement in juvenile xanthogranuloma, systemic involvement is very common and like Niemann-Pick disease, juvenile myelomonocytic leukemia. Hence, this patient was referred to pediatric oncologist to rule out systemic involvement. Fortunately, no systemic involvement was detected. These are the post-operative photos of the patient at 6-month follow-up, showing clinical recovery with mild restricted elevation. At the 9-month follow-up, the patient remained asymptomatic with normal ocular examination. Repeat MRI imaging revealed no recurrence of the orbital lesion, confirming sustained clinical and radiological resolution. Moving into the discussion, Lee et al. Reviews 22 cases of orbital xanthogranuloma, including 3 cases reported by the author. This literature review highlights that 40% of ocular xanthogranuloma may show skin involvement. Orbital cases rarely do. The average patient age was 7 months, while in our case it was 14 years, which is notably atypical. Common signs include proptosis, lid swelling, and globe displacement. While orbital xanthogranuloma often present with diffuse infiltration on imaging, our case uniquely showed a well-circumscribed mass. This atypical radiological pattern reinforces the need to include juvenile xanthogranuloma in the differential, even when imaging mimics more defined orbital masses. Histopathology is essential in orbital juvenile xanthogranuloma, as imaging alone is insufficient. It typically shows xanthomatous histiocytes and totten giant cells. Juvenile xanthogranuloma can be separated into 4 histopathological subtypes. Immunostaining helps differentiate it from mimics, highlighting CD163, CD68 positivity and negative for CD1A S100 negativity. Its clinical course remains unclear and no standardized treatment protocol exists. Reported options include observation, surgical excision, systemic or intralesional steroids, radiation therapy, and chemotherapy. To conclude, this rare case highlights an unusual presentation of orbital juvenile xanthogranuloma. The atypical imaging and clinical features made initial diagnosis challenging. Definitive diagnosis requires histopathology and immunohistochemistry. Hence, timely diagnosis is essential to guide treatment and ensure favorable long-term patient outcome. Thank you.
That was a wonderful presentation and a very interesting case, Palak. I would like to invite Dr. Akshay and Professor Ruchi to ask some questions so we can initiate the discussion.
Nicely documented and presented, Dr. Palak. I may have missed it. What was the IHC findings in your case?
Sir, we did not underwent immunohistochemistry. As we discussed with our pathologist, she is 100% confident about the histopathological findings, and as it was suggestive of xanthogranulomatous inflammation, and further no systemic involvement was seen on systemic workup, so we did not underwent the immunohistochemistry for the patient.
Right. So under the broad xanthogranulomatosis umbrella,
Yes,
it is
sir.
important to have the immunohistochemistry done, especially things like S100, CD1, Langerin, because you have to be able to differentiate it from Langerhans cells histiocytosis. So even retrospectively, it may be a good idea to take the slides and blocks and get an IHC done to come to a more cleaner, more specific diagnosis.
Yes, sir. We will do it in the follow-up.
So it was a very nice, of course, a very unique presentation. And how do you intend to follow up the patient now? Because again, as Akshay was also saying, I was about to ask the same question as to what different markers you have used and how have you planned to differentiate from other pathologies. And based on that, actually, you need to follow up these patients for a longer time. It's not, the story doesn't end here, actually.
Yes, ma'am.
So any plan of action you have?
Ma'am, as in 1 year follow-up, there was no signs of any recurrence or systemic involvement, but we will follow this patient every 3 monthly. And as sir already said that we will advise immunohistochemistry in the future follow-ups.
And in the initial part, you said that the patient had been suspected of cysticercosis. So was it a misdiagnosis? Was it always the situation was that this was the case and it was actually gradually growing to that size?
Yes, ma'am, it is there. The possibility is there that it was myocystic sarcosis at that time, and gradually that lesion resolves, and at that particular location, this lesion develops. But there are no literature suggestive of any myocystic sarcosis, cysticercal granuloma gradually developing into juvenile orbital xanthogranuloma in the future. So
So how
probably
do
it
you
was
think that
misdiagnosed as myocystic sarcosis that time.
how long was that episode when she was treated for myocystic sarcosis before you intervened?
Ma'am, it was 10 months before we intervened.
Isn't it too much of a coincidence that so many things are happening in the same area again and again?
Yes, ma'am.
So possibly it was never a myocystic sarcosis.
Yes, ma'am. Ma'am, it was probably a misdiagnosis that time, and that lesion was juvenile orbital xanthogranuloma that time also.
Yeah.
Dr. Narendra, would you have any comments to add to this case since you had managed the case?
I want to add that it was challenging because initially the initial presentation, initial history and presentation was the cysticercosis, and if you would have not done the biopsy, probably it would have been missed and mismanaged.
What
Right,
is
sir.
typical of a, whenever there is a cystic sarcosis, you said your extraocular muscle movements were never affected. And that area, otherwise, usually you have some kind of inflammation when you examine in that area, and there is some amount of involvement usually of the muscles whenever there's a cystic sarcosis. So possibly that should have put you on guard at that time, that there is something more to it.
Right.
Yes.
Thank you so much, Dr. Narendra and Dr. Palak. Dr. Rohit Saiju, sir, I would now request you to comment about this case.
Yeah, thank you, Aishi. I would like to say hi to Dr. Tarjani Bache and other doctors, Dr. Ruchi Goyal also. Probably we didn't meet, but most of the other faces are known to me. A very interesting case, Palak. Actually, this is very unique in the two sense at least. One is the age factor. The juvenile xanthogranuloma occurs usually in first or second years of the life. Another is the orbital juvenile xanthogranuloma is very rare. The commonest ocular manifestation occur in the iris and then conjunctiva and so on other parts. And I would like to just emphasize that did you watch carefully in the slit lamp about any lesion in the iris or not? If iris, there is a, the flat yellowish patch like a structure, then there is a very suspicious lesion. Though it is said that when the orbital juvenile xanthogranuloma is not associated with cutaneous lesion, but we have to rule out the cutaneous also because mostly 75% of these granuloma occurs in the skin. So in iris, why it is important, that because there could be spontaneous hyphema recurrently, and the neovascular, iris neovascular, or especially the angle neovascular things can occur in those places, which can rise the intraocular pressure and so on, the glaucoma. And this is the only vision-threatening condition can happen in the juvenile xanthogranuloma. So we have to be very watchful on this. And for the follow-up, as Dr. Ruchi has asked, we know that this is the self-regressing type of tumor or the disease that in 1 to 5 years, it regress spontaneously most of the time. But the biopsy is confirmative, but at the same time, immunohistochemistry has also similar high importance for the diagnosis of the disease.
Thank you so much, sir. Another question for you would be if you see these cases, in this case at least, we were thankfully, it was a very well circumscribed lesion which could be excised. So, what would your take be on intralesional steroids, possibly if we are just going to partially remove or debulk this lesion?
Looking at the lesion, intralesional, how much steroid to give? This is the huge one, big one.
Yes.
So instead of intralesional, you can go for the systemic steroid. Yeah, and one more remarks I would like to add that regarding the myocystic sarcosis. In the differential diagnosis of myocystic sarcosis with this granuloma, in myocystic sarcosis, you will see the cystic lesion with the hypodense lesion in the center of the cyst. That is a scolex, calcified scolex. That is a very remarkable, significant radiodiagnostic feature, and which is not here. That's why it is less likely. And the most common site for the myocystic sarcosis is the medial rectus and then inferior rectus. Somehow, what is the reason, we don't know, but it is presumed that as it depends on the amount of the blood flow to these muscle could be the site predominantly by the cysticercosis, as medial rectus muscle and inferior rectus muscle has higher blood circulation in compared to the lateral and other recti muscle.
Thank you so much, sir. Dr. Tarjini, would you like to add? You have added in the chat box, but if you could tell us.
Just Palak, very well presented. Just 2 points for you. If you go back to the radiology, the sagittal reconstruction that you have,
Yes,
that's the one with the contrast uptake, right? The
yes, ma'am.
post-contrast one. So if you look at that very carefully, look at the central area, you see a black area there, and that is surrounded by the hyperdensity. It's
Yes,
very
ma'am.
much within the inferior rectus muscle belly. The central part is not taking up contrast.
Yes,
So
ma'am.
this is where you on your pathology should correlate that is this the same area where you saw the necrosis, just for learning, not that it changes your management, but that makes you learn how to interpret radiology. You mentioned about necrotic focus on your histopathology. So, figure out where was that cut section, how was it taken of the histopath, and go back and extrapolate that is it matching with this. That'll help you read radiology better. And probably because of its proximity to the inferior rectus muscle, you have limitation of elevation at your final follow-up that you showed in your picture. So certainly some fibers of inferior rectus must be wrapped around it, which might have had some iatrogenic damage. The second is the worst of my experiences with xanthogranuloma has been where a necrobiotic xanthogranuloma bleeds profusely, bad, post-operative, very difficult to manage. And these are patients who have paraproteinemias or who have bleeding tendencies. Go back and check the CBC and see if the platelets were normal, if the other parameters were normal. And it wouldn't do any harm to actually have a clotting profile completely done, bleeding and clotting profile. That may only help the patient.
Okay, ma'am, we will keep it in mind.
But fantastic management. Congratulations to sir and you, both of you.
Thank you, ma'am.
Thank you so much, everyone. We'll move to the second presentation now. I'll request you to unshare, Palak, and the next presenter can share in the meanwhile. So as I rightly predicted, we had a nice review of the MRI films from Dr. Tarjini. And we can move on to the next presenter. We have Dr. Himani Thakur, who is currently a senior resident in the oculoplasty and oncology service at RP Center AIMS. And her presentation will be moderated by Dr. Sahil Agarwal.
Good evening, everyone. Am I audible?
Yes, Himani, you are.
Okay, a very good evening to everyone attending, and thank you, Yossi, for allowing me to present at such an esteemed platform. Today, I'll be talking about a case, the rare encounter yolk sac tumors orbital presents. So, a 19 months old girl with history of blunt trauma to right eye, followed by a rapidly progressive proptosis since 15 days, presented to us in casualty, and this is how the child looked like. So based on just the history and looking at the child, we thought that it could be a post-traumatic subperiosteal hematoma, a post-traumatic encephalocele or meningocele, post-traumatic CCF, or any coagulation diathesis, or rhabdomyosarcoma, because let's just not forget that it is the most common primary orbital malignancy in children. So on examination, we found that the patient was not following light in right eye. She had an abaxial proptosis with inferior globe dystopia. We could palpate a superior mass. There was complete ophthalmoplasia, and we could see a perforated corneal ulcer. To our surprise, the ultrasound for posterior segment was anechoic. The mass was tender. There was no pulsation or thrill on palpation, and there were no bruit on auscultation. So there were no palpable cervical, submandibular, or lymph nodes, no palpable abdominal mass. And except for the low hemoglobin, the platelets and PTINR were normal. So the normal profile ruled out our initial differential of coagulation diathesis. And due to absence of pulsations on palpation, the post-traumatic encephalocele or CCF were unlikely. So next, we got a contrast enhanced CT done for her, and we found a 31 into 33 into 36 millimeter well-defined heterogeneously enhancing mass lesion in superior orbit, which was abutting the globe, causing its anterior-inferior displacement. There was no evidence of fat stranding calcification or hemorrhage, and there were no adjacent bony erosions or intracranial extensions. So our initial differentials were all ruled out, and we had to add newer differentials of tumors. So it could be a neuroblastoma, but then there were no raccoon eyes or periorbital ecchymosis, atypical RB, but then there were no intraocular involvement, but still it could be a diffuse infiltrating retinoblastoma. Also, to down the list, we added orbital capillary hemangioma because it is the most common benign periorbital tumor of childhood, although there were no cutaneous or subcutaneous lesions in the child, or there were no flow voids on imaging. So the next step that we could give us a diagnosis was incisional biopsy under general anesthesia. And meanwhile, the patient, when she came to us with biopsy, we saw that the proptosis has progressed so much, and attaching is the MRI of the patient. So now at this point, we were very sure that it is some form of tumor which is aggressive in nature. So to our surprise, the histopathology showed tumor cells arranged in a microcystic pattern with Schiller-Duval bodies. So Schiller-Duval bodies, these are papillary structures within cystic spaces, which are lined by cuboidal or columnar cells, and they are, when present, pathognomic of yolk sac tumors. On further magnification, we saw tumor cells with extracellular hyaline material. And next, on immunohistochemistry, they were SOL4 positive and placental alkaline phosphatase positive, and negative for Desmin, which ruled out our rhabdomyosarcoma. So the histopathology was consistent with the yolk sac tumor. We further investigated with a serum alpha fetoprotein, which is also the gold standard for diagnosis of yolk sac tumor, and it was, as expected, increased with a normal beta HCG serum. So our diagnosis of extragonadal yolk sac tumor was established. We next did a whole body PET CT scan, which suggested a metabolically active right level 2 cervical lymph nodes consistent with query metastatic disease. Otherwise, no metabolically active tumor was seen elsewhere in the body. So based on the POG staging of extragonadal germ cell tumors, ours was falling into the stage 3. So after discussing it with a medical oncologist, we started with a platinum-based chemotherapy, which consisted of bleomycin, etoposide, and cisplatin. So it was decided that 3 cycles will be given, followed by a response assessment. So after post 3 cycles of chemo, we found a drastic improvement, and the proptosis had drastically decreased, but still there was residual lesion in the orbit with a thiacical glow. So we can see how the tumor has decreased, and the serum alpha fetoprotein has also decreased. So what would be the further management? So next, the patient is planned for right eye exentration under general anesthesia, followed by the 4th cycle of chemotherapy. So talking about yolk sac tumors, malignant germ cell tumors account for 3% of childhood neoplasm, and yolk sac tumor is the most common among them. And extragonadal germ cell tumors of head and neck are very rare, and they comprise only 5% of all germ cell tumors. They have a rapid progressive course, and during 4th to 5th week, when the germ cells migrate through midline dorsal mesentery before reaching the gonadal ridge, it is proposed that remnants of cells along the migration path can lead to these germ cell tumors. I want to highlight the importance of alpha fetoprotein, which is important in diagnosis, management, as well as prognostication of the disease. So it is the gold standard for diagnosing. It is important to monitor the response to chemotherapy and even monitor the early tumor recurrence. And serum alpha fetoprotein more than 1000 microgram per liter is associated with a worse prognosis. Other immunohistochemistry markers are SAL4, placental alkaline phosphatase, glypican 3, and cytokeratin. So yolk sac tumors have a bimodal distribution. They present either in the first 4 years or post-puberty, with the mean age of presentation of 32 months. The mean duration of presentation is 2 weeks, and they are overall more common in males. But when it comes to pediatric tumors, females, these are more common in females. They can have a varied presentation from proptosis to nasal discharge. And since the tumors are so rare, there is no well-defined guideline for the same, and it consists of a multimodal management with chemotherapy, surgery, and radiation. The 5-year survival for extragonadal yolk sac tumor is 66 compared to 81 to 89 for gonadal yolk sac tumors. But even among the extragonadal yolk sac tumors, orbital ones have a better prognosis because first they present at a younger age and they cause noticeable proptosis. Hence, the treatment begins early. So the take-home message by my presentation would be that it is important to know this exceedingly rare tumor because first, it is difficult to differentiate it from rhabdomyosarcoma, and it carries a poor prognosis than rhabdomyosarcoma. Plus, the treatment protocols vary considerably. Thank you so much for your time.
Thank you so much, Himani. That was very, very interesting, exceedingly rare. So, and also I'd like to congratulate you on the documentation with the serial imaging as well. So we really have an idea of how rapidly this tumor progresses. I'd like to invite Professor Ruchi and Dr. Tarjani for questions and comments.
Actually, a very well worked up case, I must say, and I must congratulate you and Sahil both for really working up the patient well, managing the patient. Just that I don't know why you kept subperiosteal hematoma as your first differential. I would never have kept it the way you would see that the differential sequence I would not agree with you. Otherwise, I think it was a flawless workup and management.
Thank you, ma'am.
Yeah, Himani, fantastic case. And my experience of seeing or managing a yolk sac tumor is just N=1. I've seen one case in my entire career very recently, which actually sort of highlighted a few points. If you look at, I agree with Dr. Ruchi. I would actually have put before the radiology, an lymphangioma or a venolymphatic malformation with the formation of a chocolate cyst as my differential higher up than of course the radiology is very different. But then going back to the radiology, if you can just put up that slide which had the radiology, these are tumors that have both solid and cystic components, very similar to what a lymphangioma has. And classically, if you read literature on yolk sac tumor radiology in the gonads, you'll see that it has a reticular pattern, honeycomb appearance. And look at your scan there, you'll see that little reticular pattern or honeycomb appearance on your scans. So that's probably the one thing. The case that I managed, I was so high on thinking of it as a lymphangioma. But then, and I took the child up for aspiration and sclerotherapy, but the aspirate was unusual. It was not like the aspirate of a venolymphatic malformation. And I sent that for cytospin, and that showed a yolk sac tumor. So that high has to be your level of suspicion for tumors like this. Obviously, when you see this form of indentation of the globe, right, it is the solid component or something that's very tense in the orbit that's indenting the eyeball, and that's that classic reticular or honeycomb appearance that a yolk sac tumor has. So that's the only point. Otherwise, fantastic presentation and great management.
Thank you.
Just
Thank
a quick
you.
question, was any systemic screening done?
So whole body PET CT scan was done for the patient.
Yeah, I'd like to invite Dr. Sahil Agarwal, who's an assistant professor at RPC AIMS, who has managed this case. Sir, any comments from your side?
Good evening, everyone. I'm just grateful to Yossi for having me here and allowing us to present this extremely rare and challenging case. I'm proud with the way which Himani has presented the details with clarity. Thank you so much.
Thank you, sir. Professor Rohit, any comments from your side? Very interesting case, and also how you would have probably followed up this patient once the chemotherapy and considering radiation as well as an option for this patient.
Very well documented, the diagnosed and well managed case, and very unique, also very challenging. And looking at the aggressive nature of the case, and first, probably in my mind, it came as a rhabdomyosarcoma rather than the other differential diagnosis. But the things what should be done has done very nicely. Put the diagnosis in time and manage in time. And surprisingly, how the chemosensitive this tumor is, it just melts like a snow in the sun. So within 3 cycles, it came to almost normal size. That is fantastic. I would congratulate, well managed case. Thank you.
Thank you, sir. Dr. Tarjani, I had a question regarding your case that you managed. What was the aspirate like? Like, how did you get suspicious?
You know, when you aspirate a lymphangioma, you get that straw colored fluid if it's old or frank, blood-like fluid. This was white particulate. So it looked very, very different on aspirate. And that's when I wanted to send a biopsy as well, but it was just bleeding all over the place. And it was very difficult for us to control bleeding with a globe completely out like that. My patient actually did not have exposure keratopathy, but had extreme rhabdosis and seemed to have reasonable vision. There was no RAPD despite it being so large. So I was worried about vision and I just sent the aspirate.
So you did not inject the sclerotherapy because you were suspicious.
Yeah.
Okay.
So Dr.
Thank you.
Tarzani, how many cases have you seen this yolk sac tumor?
One.
Only one, yeah.
One.
And Himani, you are very lucky. You have seen in the earlier career, you have seen.
Right, sir.
I have also seen only one.
I've also seen just one.
Yeah.
And even for us, ma'am, as you said, the bleeding was the most challenging thing that happened on table, and it was extremely, difficult. We did not know how should we go about. And with the GA, the child had hemoglobin as poor as 8.5, so we did a transfusion. We kept extra pint of blood ready on the table.
Very well managed, Sahil.
Thank you so much.
Congratulations.
Thank you.
Dr. Akshay, how was your case? Like, how did you approach that case?
So this was an excisional biopsy was done. It was not as proptotic. In fact, Himani had put the photograph of that case from our paper as well, which was published. The child with a small superomedial lump. So it was a smaller tumor, and a complete excision and serial follow-up was all that was needed. There was not so much of exposure keratopathy.
Sir, if I may add, I would like to say that when I did the review of literature, I found cases where the tumor completely vanished with chemotherapy. And yours was, I think, the only lucky patient which was completely excised, and I think he is tumor-free now.
Yes.
That's a wonderful discussion, and I think Himani has an opportunity of a case series on her hands with one case from each panelist. So
The
that's
mentor
very
and the judge panel can collaborate and
absolutely.
publish.
We should, ma'am. Thank you. We should, Dr. Akshay. Thank you so much.
So we'll move on to our next presentation. Himani, if you could please unshare, and
Yes,
we'll have
thank you
Neha
everyone
share
for
that.
your time.
Thank you, Himani.
Can you unshare your screen? Yeah. Dr. Sumay, we can move on to our third presenter.
Yes. Yeah, so the next presenter is Dr. Neha Chaudhary, who is currently a phaco-refractive fellow at Nanda Deep Eye Hospital. And my co-moderator is also going to be her mentor, Ayushi Agarwal. Neha, can you put your slides on?
Am I audible, sir?
Yes, you're audible. Just put your slides on slideshow and then we can begin. Yeah, great. You can start.
Good evening, everyone. Today I'll be presenting an interesting case of a 50-year-old gentleman who presented to the emergency department with complaints of diffuse swelling around the left eye since 4 days, associated with discharge and watering since 4 days. The patient gave an alleged history of fall from bike 4 days ago, which was not associated with loss of consciousness, nausea, vomiting, nasal bleed. There was no prior intervention that was performed before a presentation. Also, the patient did not give any history of trauma from a specific object. My patient is hypertensive with on antiplatelet therapy. He's also chronic alcoholic and a chronic smoker. The general examination and systemic examination was within normal limits. On examination, the best corrected visual acuity was found to be 6/6 for distance and N6 for near in the right and the left eye respectively. The ocular motility was full and free in the right eye, whereas there was restriction in levoversion, levodepression, and levoelevation in the left eye. As you can see on external examination, a 3 mm abaxial proptosis was noted with a vertical and horizontal dystopia and also a superonasal globe displacement. As per the clinical picture, we can see a periocular edema with discharge near the lateral canthus, suggestive of a conjunctival abscess. A CT scan was requested, and as we can see in the axial view, a linear hyperdense lesion is seen on the lateral aspect extending to the posterior orbit. It is also surrounded by a hypodense area and an isodense boundary suggestive of an abscess. In the posterior coronal view, we can see that the lesion is located between the lateral rectus and the inferior rectus. The posterior extent of the lesion can also be seen in the sagittal view. So based on the clinical features and my imaging, my provisional diagnosis is left orbital cellulitis secondary to intraorbital wooden foreign body. So on the day of presentation, the discharge was sent for microbiological investigation and the smear showed gram-positive cocci. The patient was started on broad-spectrum antibiotics and was planned for an urgent left eye orbital foreign body removal under GA after 3 days. So this is a clinical picture on the day of surgery, that is day 4. We can see that the inflammation was drastically reduced. The lateral abscess was more organized. However, the dystopia was persistent. So intraoperatively, we preferred to go for a lateral canthotomy and a cantholysis approach. So we decided to go through the abscess roof for ease of surgical access. And a meticulous dissection was performed until we reached the tip of the wooden foreign body, after which the blunt dissection and tenotomy was done. And the foreign body was retrieved. The foreign body was about 3 centimeters by 1 centimeters. After that, a thorough debridement of the necrotic tissue was carried out. We also checked for any residual fragments, and when we found none, an intraoperative irrigation with antibiotic and betadine was done. We left the wound open to heal. The retrieved foreign body was sent for culture, and the growth of Aspergillus teres was noted. This is a clinical picture at post-op 1 month. Post-surgery, we had started the patient on systemic antibiotics, amoxicillin and clavulanic acid, anti-inflammatories and topical antibiotics. At post-op 1 month, the inflammation, dystopia and proptosis were resolved. The wound side also healed well, and the abduction was full and free in the left eye. So wooden intraorbital foreign bodies generally present as orbital cellulitis, proptosis, or orbital apex syndrome. The radiological features of wooden foreign body are dependent on hydration. As in the acute stages, the wooden foreign bodies will show hypoattenuation, which is similar to air. In subacute stages, the attenuation appears similar to the soft tissues, or it appears isodense. And in the chronic stages, there is hyperattenuation due to granulation tissue and inflammatory response. Because of this, it is very important that we request the radiologist for a wider window width of around 1000 Hounsfield units and a window level of around 500 Hounsfield units. As per literature, wooden foreign bodies tend to splatter, and hence it is recommended to do a post-op MRI check. So, to summarize, all cases of suspected intraorbital foreign bodies should be thoroughly examined both clinically and radiologically. And based on the nature, the dimensions, and the position of the foreign body, the management strategy, that is either a surgical removal or a conservative management, should be planned. To conclude, intraorbital foreign bodies are notorious masqueraders, and we should always suspect intraorbital foreign bodies in any case of facial trauma which is presenting with orbital inflammation. All of the wooden foreign bodies, as I said, tend to splatter, and hence meticulous dissection should be done around the involved area. And we should always look for splinter fragments. Thank you so much for your time.
Can you switch on your video?
Yeah.
Thank you so much, Neha. It's great to see that Ayushi has sparked some oculoplasty interest in a cataract refractive fellow, and you've presented really well. I'd like to invite Dr. Tarjini and Dr. Akshay for their comments.
Yeah, hi, very well presented.
Thank you, ma'am.
Neha, a few things that come to my mind. How many days after trauma did you take up the patient for radiology?
Ma'am, the patient presented to us on day 4. That is, so immediately on that day, we sent him for radiology.
Yeah, it's very surprising to see that it's pretty hyperdense that early into the, peri-trauma period, because and you presented, if I'm not wrong, a CT, right? I think I
Yes.
saw scan, yes. So generally the teaching is that you'd prefer an MRI to see wooden foreign bodies. They're difficult to pick up on CT scan. So any reason you asked for a CT?
Yes, ma'am. Actually, the patient did not give any history of trauma due to a specific object. So we were not sure if the object is metallic or non-metallic. And just to be on the safer side, we went for a CT scan rather than an MRI, which would have displaced the metallic if it was a metallic foreign object.
Right. So generally probing a little more into the history as to when he fell from the bike, where exactly did he fall? Were there bushes around? Such a big piece of wood going into the eye should have, some history come out, unless the patient is a very, very bad historian. You said he's chronic smoker and alcoholic and all of that. So I don't know if that plays a role here. But besides that, you said that you send the foreign body for culture. Is that right?
Yes, yes, ma'am.
That's the second point. You send the foreign body, it'll grow a zoo. It'll grow everything. So what you actually need to send is the pus.
We had sent the pus only, Dr. DVD.
Okay. You
Yeah.
sent the pus. Okay. So that's good, because I thought it was the foreign body that grew the
No.
fungus and then he responded to antibiotics. I was a little confused there. But otherwise, great. Ayushi actually has personal experience of managing wooden foreign bodies, suspecting when to or suspecting correctly that there has to be a wooden foreign body here. She's co-managed several cases with me, so very, very well managed and very well presented as well.
Thank you, ma'am.
Thank
I
you.
think the
The only
point that
thing, the
Yeah,
only
yeah,
thing that was not matching was the timeline and the hydration on the imaging. That is why I had taken your opinion also. But it was, but it was like the high suspicion was of wood only. But the only thing against it was the hyperdense status at day 4.
Yeah.
And any clinical implication of the fungus growing? Did you do anything on that?
So, Neha, please answer that.
No, sir. Actually, when we sent the discharge on the day of presentation, when we sent the discharge for microbiological investigation, we found gram-positive cocci, and we started the patient on broad-spectrum antibiotics, and the patient responded really well to it. So there was we did not find any particular reason to start an antifungal. Also, as per literature, there's a lot of controversy on whether or not we should start antifungal prophylaxis for wooden foreign bodies, because they tend to have fungal elements.
Yeah, so basically this is a clinically insignificant growth that you're seeing, and you really don't have to add any medication in immunocompetent patients. So
Yes.
You have to stop the blood thinners. He was on aspirin or something like that.
Yes, yes, ma'am. He was on antiplatelets, and hence we had to defer the surgery 3 days later.
Just one
Which
point to add.
antiplatelet effect goes away in 3 days?
Yeah.
So,
Why did you like in a case of orbital cell late, why didn't you start IV antibiotic? Like I would have been in your position. Augmentin is a little with so much of resistance coming in, and I think that already the patient was into orbital cellulitis by that time. So why was I think you gave Augmentin initially?
yes, ma'am. Systemic oral
You
treatment.
were lucky that the patient responded so well. And Ayushi, very good, well dissected case that the whole of the foreign body were pulled out. Have you gone for a check MRI now?
Done it.
Neha, do you want to answer that?
Yes, ma'am. Ma'am, the patient was non-affording, and also at 2 weeks follow-up, we found that the inflammation had resolved. So we did not go for a check MRI. However, it is recommended and should be performed for all patients.
I think you have burned your fingers, Ayushi. If you remember one case we had, that patient was explored, and then after subsequent MRIs, the orbital wooden foreign body was picked up. So I would still say that the patient may be quiescent for a while, and you still should go ahead and counsel the patient to go ahead and get it done. Sometimes small bit of pieces may be left behind.
Absolutely correct, ma'am. So I've actually seen wooden foreign bodies with Professor Ruchi Goel, ma'am, as well as Dr. TVD. So yes, I agree, but it's just that the patient doesn't follow up regularly, and he is not willing for a repeat imaging.
Professor Rohit, comments from your side?
May I ask Professor Ruchi, what is the choice of antibiotic for the orbital cellulitis in first glance in these cases?
Yeah, I would have gone for intravenous because we had done a study here at our center when I was at MAMC, and we saw that we had actually done cultures for our dacryocystitis patient, and there was 70% resistance in our with Augmentin at that time. So of course, still we would not go for the next level IV antibiotics immediately, but patients who already has this kind of a presentation, then I would have started a cefuroxime injectable at least, or maybe Vanco when there was gram positive. That would have been a good idea, not to take chance. It's lucky that the patient was not resistant and responded well. But then you really need to sometimes, get a quick response and then go in for an early intervention.
Thank you
Yes,
very
sir.
much. Still, I think the ceftriaxone is very good in our experience, and the flucloxacillin also covering the gram positive is doing well. So blindly when you start in the beginning till the culture sensitivity report come.
Yeah.
Neha, very nice presentation, and I think
That's it.
everybody has here experience of the wooden orbital foreign body management, and same in our countries also, especially the agriculture, harvesting and plantation time. A lot of cases come with the orbital foreign body, especially with the wooden part, splinter or wooden foreign bodies. Yeah, I agree that when the history has taken very nicely, and your patient will tell that where and how the trauma has will give the clue about the what is the type of the foreign body in the orbit, and that will give you which radio imaging should be done by the primary investigator. So MRI is the first choice here, though primary orbital imaging is CT in the most of the other cases. But once you have the history of the orbital wooden foreign bodies, then the MRI is the best. And even the small splinter can be suspected in MRI, what can be missed in the late investigated CT film. As in the early stage, the CT will not give the very nice features of the foreign body. Only in the late stage, as it became the radio dense. And yeah, definitely, if the history is not clear, like the flying high velocity objects like the glass metal, then the CT is the primary radio imaging investigation we ask. And regarding the management, Neha has done very well. At the key principles, just to recall back that, just look for the entry port. Usually entry port happening on the skin or the conjunctiva, and that port should be very closely and widely explore and find out, just debride all the necrotic tissue, how much can be done, and try to find as much as all the foreign bodies which are visible. And at the time of the exploration and debridement, we do the antibiotic lavage also. So Neha has done very nicely. Lavage with, I do especially with the cefazolin and the gentamicin or amikacin, so gram-positive and gram-negative coverage. And then keep open that. If still the sinus with the discharge is there, that suspect still some part of the foreign bodies is there, and do the MRI again and find out the exact location. And so all the foreign body doesn't come at once in one go. So most of the this long, like the 3-4 centimeter long wooden splinter up to the auricular apex, they reach, and sometimes the patient is very quiet, that the opening portion has granulated somehow with this limited discharge, but there is a big foreign body is suspected. So wherever you see the opening entry port, you have to explore very widely, debride, and antibiotic lavage as a principle for the management of these cases.
Yes.
Thank you.
Really well. Thank you, sir. I just want to make one more comment as well, is that one thing that Neha pointed out of the imaging, where we ask for the increased window width as well as the Hounsfield unit, because being in touch with our radiologist and maybe even specifically calling them or informing them of what is the nature of the foreign body we are suspecting will help with innocuous foreign bodies, which we might miss in case the radiologist is not looking for them. So we'll move on to our next presenter. Ayushi, you can introduce the next presenter.
Yeah, so I'm glad to introduce our next speaker, Dr. Ashwita Alva, who's currently doing her fellowship in oncology and oculoplasty at Center for Sight, Hyderabad. She has been mentored by Dr. Rolika Bansal, who has recently finished her international fellowship and is now back in Jaipur. So, Dr. Ashwita, you can share your screen.
Very good evening,
Yeah,
everyone. Thank you so much for this wonderful opportunity. Cox or SALS, two different names, two different entities, and let's see how they merge seamlessly. So dissecting this case of a patient who walked into our OPD, is my slide moving? Yeah. Who walked into our OPD, a mysterious case in fact, as the patient was vexed with a prolonged duration of redness and severe pain. Now let's take several steps back. He was a 26-year-old male who was a known case of extrapulmonary COX and was treated with anti-tubercular medications 4 years ago. And then he presented to the local ophthalmologist with right eye severe redness and pain. He was diagnosed with nodular scleritis. He started off with a vision of 6/9. With a backdrop of ocular tuberculosis, he was started on steroids and anti-tubercular medications again. This was supported by evidence of Manto being positive, and AC tap was done, which was positive for MPB64. Then they performed an ultrasound and found a choroidal elevation with scleral thickening and subtenous fluid. For 2 months, he was on tubercular medications, yet the clinical features continued to worsen and the visual acuity dropped to 660. They did a fundus evaluation and found that there was tubercular abscess and went ahead to give intravitreal moxifloxacin injection. 3 months later, a vitreous biopsy sample was taken and it was tested negative for TB-PCR. He was continued on steroids for 9 months and was advised on right eye enucleation. So then he came to us, a mysterious case of diagnosed ocular tuberculosis with the visual acuity as low as no perception of light at all, developed complete ophthalmoplegia while on treatment and showed no signs of resolution. What was interesting to note was there was volume loss in the right eye, yet there was no enophthalmos. So then we went ahead to think that this is suggestive of an right eye orbital mass and mandated an orbital imaging to reach a conclusion. MRI orbit with contrast showed a well-enhancing soft tissue mass covering the entire orbit, encasing the orbit and the optic nerve, and also involving the right lacrimal gland. This not only caused complete thusical eye, but also compressed, distorted, and caused disorganization of the right globe. On the basis of clinico-radiological judgment, steroids was discontinued for a period of 3 weeks, and a multi-level incisional biopsy was taken from the superficial, intermediate, and deeper levels. On histopathology, interestingly, we found marked lymphocyte and plasmacyte infiltration with areas of fibrosis. So here we had a case which was growing, had granulomatous inflammation, was completely infiltrating the globe, and later responded to glucocorticoids. Bringing all the G's together, we went ahead to do an IHC and found more than 55 IgG4 plasma cells with a higher than 40 ratio of IgG4 to IgG. Going back, the serum IgG4 levels were also raised. It was 1513. Therefore, we came to a diagnosis of IgG4 related disease. As all the three criteria of clinical, hematological, and histopathological criteria was met, we diagnosed him with definitive IgG4 related disease. We reinitiated steroids with intravenous methylprednisolone with a loading dose and a 3-weekly maintenance dose, and added on mycophenolate mofetil of 1 gram at 4th cycle of 5 AMP. He had a dramatic improvement at the end of the treatment with very good improvement in his symptoms, decreased redness, decreased pain, and also an MRI orbit with contrast was repeated, which showed that the proptosis resolved and there was near total resolution of the enhancement. So once he was stable, we went ahead to do a right eye enucleation by minimal manipulation myoconjunctival technique, thus providing a good cosmetic correction as well. At this point, you may wonder, why was enucleation not done at the very beginning? Let me bring to your notice that it is extremely essential to treat the entire condition first and control the underlying disease before intervening surgically. This not only provides a good functional and a cosmetic outcome, but also prevents recurrence in the further state. So when we saw this case on that busy day, it was broken down by an algorithmic approach where we suspected a mass pushing the globe forward despite the eye being thusical, indicating that there was a dense fibrotic mass, and thus these were the differential diagnoses we began with. Certain studies also state that IgG4 related disease can occur during or after a TB contact. On review of literature, we found that our patient was relatively younger than the others stated. There was raised IgG4 levels found in all patients, and the treatment protocol was similar, thus preventing further recurrences. So putting it all together, here you have the pole-to-pole manifestations of IgG4 related disease in this one patient from the anterior to the posterior segment. With multiple differentials in mind, we aid the diagnosis with radiological evidence, the blood markers of IgG4 levels, and finally the histopathological criteria. All this helps in an early diagnosis and helps in the providing the treatment with steroids and immunomodulators, thus aiding in an excellent outcome. So you ask, why Koch's assaults? From Robert Koch, who first described Mycobacterium tuberculosis, to Henry Salz, who first described IgG4 related disease in the pancreas, this case reminds us that orbit can blur the lines between an infection and an inflammation, and only careful diagnosis can set the story straight. Thank you.
Thank you so much, Ashwita. That's a very crisp presentation, and it really does always amaze us, the orbit. So we have comments from Professor Ruchi and Dr. Akshay first, and then we can move on to the rest of the panel.
Yeah, very rare presentation. And just I want to again go back. On what basis was the patient diagnosed as tubercular?
His Manto test was raised, it was 20 mm, and they did an AC tap. So that was found to be positive for MPB64. Initially, this was all done elsewhere, and there the AC tap showed MPB64.
Were there any extra pulmonary, any pulmonary signs of tuberculosis or any other signs?
No, ma'am, only HRCT was done, and that had no signs. Just the extrapulmonary tuberculosis was there 4 years before he started with all the ocular features.
So again, as I would again go back and say that maybe it was never Koch's. Contours positivity is not a clear-cut evidence. So possibly he was always having this problem only, and ATT was not the right treatment. So, and of course, IgG4 presentation of this sort, we have all, I think, seen all kinds of weird presentations of IgG4 where, and again, one more thing, I like, why did you go for enucleation with that kind of a what was ultimately after you had given steroids and everything, what was the look like? I would have rather waited and not gone for immediate enucleation, because actually the disease was in the orbit. So
Yes,
why did you go?
after the disease completely resolved and the
How
MRI
long after your treatment did you go for enucleation?
three months after completing the steroids and immunomodulation, we did a repeat MRI and saw that the eye was thicycle and his IgG4 levels were relatively lower than what he presented to us. And then the patient wanted a better cosmetic outcome as well. So then we did an enucleation. And on the enucleation sample as well, the histopathology revealed only a thicycle eye. There were no signs of IgG4 in that.
And the patient has been followed up after that as well. And the patient has been stable thereafter as well.
Okay.
So, Dr. Ashwita, what is the systemic implication of having diagnosed this patient with IgG4 now?
Now, most importantly, it can also involve the pancreas, the salivary glands, and cause inflammation elsewhere. So, a pancreatic amylase test or a whole body PET CT scan would be required, but maybe because the intravenous methylprednisolone as well as immunomodulators brings the systemic results in control, we did not go ahead to do so much, and the patient is systemically fine. But in those cases, to rule out other systemic manifestations of pancreatic amylase would be necessary.
Yeah, so I mean, when you look at, they have something known as SIR, or standardized increased risk ratio, of systemic lymphomas in patients with IgG4 disease is nearly 4 times more in patients with IgG4 disease as compared to those who don't.
Okay.
So serial follow-up is most important in these patients.
Yes, so we call the patient at every month initially for the first 3 visits, and then after that every 3 months, and then 6 for a year, to see if he is having any other new recurrence like symptoms or any systemic manifestations.
And at presentation, there was, when he came to y'all, the patient had a frozen globe with phthisis, right?
Yeah, he was pre-thicycle, but there was severe inflammation around. The eyelid edema was present, and conjunctival congestion was present.
So how come the patient, even though was being treated with oral steroids at that time, did not respond to the oral steroids previously?
So the initial picture which I showed, there was chemosis and conjunctival congestion. This is the photographs he has sent to us from before receiving the treatment. And later the chemosis and congestion reduced a little bit, but the proptosis continued further, and his vision started to drop further. So those continued.
No, I think what he's asking is that initially also steroids were being given. How come they did not respond? So you're right. It was just the regimen was not being strictly followed. However, the regimen that we gave eventually after the washout worked on the patient very well, and it sustained. And we're not very sure whether the regimen was given properly or not. These are just paperwork that was conveyed to us.
True. And I'm not very well read, and fiction is not my forte. I still did not get Cox or Salz. Can you explain that? What is Salz?
Salz was actually, Henry Salz was the first who described IgG4 related disease in the pancreas in 1961. So just from the name of scientists, I just put that.
Thank you.
That was first described in Japan, yeah?
Yeah, that's what I thought.
I also thought that there should be some Japanese name rather than Henry Salz. I'm not sure. Just I heard like that.
Ashwita, I had a question for you. Did you
the orbital biopsy for microbiology workup and PCR for tuberculosis?
Yes,
Given
ma'am.
much history already.
Yes, ma'am. Zeal-Nielsen stains was done and it was negative. And even TB-PCR was done for the orbital sample as well. And that also tested negative.
Okay, so is IgG4 workup a part of all your orbital biopsies? What prompted you to send it for IgG4 stains?
So when the patient presented to us, we got a complete collagen vascular profile because we had even IgG4 related disease in our differential diagnosis and sarcoid in our differential diagnosis. So that time the levels was 1512, which is raised. And then since on histopathology there was increased lymphocyte and plasmacyte, then we went ahead for IHC.
Okay. So, right. So that's one. Second part, like Akshay mentioned, it seemed like your patient had total ophthalmoplegia.
Yes, ma'am.
I see the picture with the prosthesis, the ptosis doesn't seem to be apparent. Is it just the prosthesis which is lifting the eyelid up, or did the ophthalmoplegia reverse to an extent?
No, then we went after doing the enucleation, we did a tarsofrontalis sling, and that's why the eyelid is lifted up. But he did have a complete ophthalmoplegia with complete ptosis.
Yeah. So another small pointer, because socket again is something very close to my heart. So I would probably not have enucleated this. I would have done an evisceration and sent the sample for histopath nonetheless to look at what is happening, and probably placed a little larger implant than what you've done because there's residual sulcus deformity and lower eyelid retraction, which means your implant is smaller, your prosthesis is heavier.
Okay.
And I would probably have just given a confirmer and seen that if he is, I agree with Dr. Goel, so early on, 3 months into the resolution, I would probably not have operated. I would have, if he was very concerned cosmetically, probably done a confirmer trial and given him just a scleral shell over his thicycle eyeball.
Yeah, but we tried that in the beginning, ma'am, before we went ahead with the enucleation, and he was not comfortable with the whole procedure of placing it. So then after that, we decided for enucleation.
Right.
Thank you so much for the questions. Professor Rohit, do you have any comments before we move on?
Very nice. The case to discuss and get in consensus. Putting the diagnosis for the tuberculosis 1-2 test is not very supportive. It means that once in the life the patient has contacted with the microbacterial bacillus. That doesn't mean there is a tuberculosis active case. And I'm very much confused with the status of the globe, whether it was pre-thicycle or thicycle before the disease described, or happened after the tuberculosis or the IgG4 has diagnosed. This could be the pre-existing eyeball status, like a thicycle or pre-thicycle conditions, and doesn't matter with these two diseases. Could be one possibility. And doing the myocutaneous bioconjunctival enucleation in thicycle eye is technically not very easy as the other eyes. So if you have done that myoconjunctival technique, that is great. But usually in the thicycle or atrophic bulbi, it is difficult to identify each and every muscles, and then suture over this conjunctiva is technically a bit difficult for me. Otherwise, I would say that's a great presentation, because IgG4 is a very vague type of presentation, and the other things are not very straightforward, like it is delimatous disease, and you have done well job. Congratulations, Aswita.
Thank you, sir.
Thank you so much, everyone. So with this, I'll request Ayushi to make a few announcements before we conclude the session.
Is my screen visible?
Yes, Ayushi, it's visible.
Thank you. Thank you so much, everyone. And now it's time to announce the winners of the previous session that was on eyelid, held on 20th July. So our second runner-up is Dr. Devika Malhotra, who presented a very good case about mucin adenocarcinoma of the right lower eyelid under the mentorship of Dr. Narendra Patidar. She's an oculoplastics fellow from SNC Chitrapur. Our first runner-up is Dr. Yashodhara Singh, who presented a very interesting case on eyelid sarcoidosis under the mentorship of Dr. Narendra Patidar. And now comes the winner, Dr. Haig, who also presented a very interesting case on sarcoidosis, but had a very different presentation under the mentorship of Dr. Sahil Agarwal. I congratulate all the winners. And thank you so much, everyone. Over to you, Sumer.
Thank you so much, everyone. This was a wonderful session. I'll conclude the session with a vote of thanks. I want to thank Professor Dr. Rohit Saitlu firstly. Thank you so much, sir, for taking out the time and enriching this session with your presence. You have done so much for the field of oculoplasty, and for you to take out the time for us. Thank you so much.
My pleasure, Sumer.
I'd also like to thank our panelists, Professor Ruchi Goel, Dr. Tarjini Dave, and Dr. Akshay Nair. We had a very interesting conversation and a lot of discussion, which will be very helpful for the people who have joined us live, as well as the people who will watch this in the future on YouTube. Secondly, Ayushi and Puneet sir and the entire ExPresYO team, which have taken out such an interesting session for young people who want to present and may not always have the platform in their medical colleges, and they get the experience of a mentor where they can really truly express themselves and truly go through how it would be in the future in conferences. So Ayushi and team, you all are doing a great job. This is the third session I have attended, and I've really learned a lot. And finally, our team, which is helping us with keeping up these webinars, Manjula ji, thank you so much. Ayushi, would you like to add anything before we end the session?
Yes, if we can have a quick comment from our expert panelist and sir about any feedback that we can do better or anything like that.
You're already doing great.
Ayushi, this is a very innovative type of webinar among the fellows and junior colleagues, bringing in the conjunction with the experts. That's very great. And maybe you can join if this extend, or you have the plan to extend this, you just go beyond the India and come around with the surrounding neighboring countries like Bangladesh, Nepal, and other countries also. So that will be much beneficial for all the oculoplastic service.
Thank you, sir. We'll definitely work on that. Now I would request everyone to switch on their videos. We'll take a customary UC picture. Can everyone switch on their videos?
With smile, yeah?
Yeah, with smile and this sign. Yeah. Everyone ready? Yeah. Done. Thank you so much, everyone. Despite being busy and having health issues and from different time zones and around these festivities, for still taking out your time and contributing to this wonderful program. Thank you so much.
Thank you. Thank you. Good
Thank
night.
you, everyone. Thank you.
Enjoy the